Okay, so hello everyone, and welcome to another virtual morning report. Thank you for joining us today. I was wondering if there's anyone who's joining us for the first time today, you may open your mic and you may share where you're from. Also, if anyone has a case that they'd like to present today, please feel free to do so.
Ibrahim, I think I saw Adriana raise. I thought I saw Adriana raise a raised hand from Adriana's screen. Am I completely hallucinating? Hello.
Oh,
Adriana.
hello, Adriana. If you can please unmute.
Oh, you have an issue with your audio. That's what you were trying to say. Gotcha. Amazing. Tell us in the chat,
Okay.
Adriana. You might not be able to unmute, but tell us in the chat where are you joining from? I think this is the first time we're meeting you. It may not be the first time that you've joined, but tell us in the chat where you're joining from. Oh, there's something wrong with your audio. I'm so sorry. We can't hear you. Ah, bummer. Next time. Next time. Ibrahim, how are you feeling? It's your first discussion. Well, first, you've already had half a discussion. Come on. How are you feeling now?
I'm feeling excited. Looking forward to today's case.
Amazing. I love the powering through. I love the power. All right. Well, I think I don't think anybody in the chat has a case, but we have David from Spain, one of our team members who has a case for us, which gets me very, very excited and nervous at the same time. Really, really excited. So why don't you say hi and then we'll jump right in, okay?
Hi everyone. Hope everything's fine. I can start when you want. So I start. This is a 33-year-old woman who came to the ER with complaining of generalized weakness. I can stop there, or I can go a little bit more, as you prefer.
What do you think?
Yeah, so I think there's actually a lot of important information when it comes to weakness. So we may actually go through this case through regional or anatomical approach, and we can go through it whether this is proximal versus distal weakness. And this way, the other way would be something that if we are thinking about the systemic process that is going on. And for systemic processes, to be honest, what I first have in mind when approaching weakness is something like a neurological disorder, something like myasthenic gravis, Guillain-Barré, ALS, although this is a female, MS as well. And then for muscular disorders as well, it would be something like myopathy, polymyositis, dermatomyositis, even though dermatomyositis would be something typically proximal and most likely localized to the upper limbs. And then there are also metabolic disorders that I feel should be kept in the back of our minds at all times. Those include things like diabetes, as well as electrolyte disorders. We can also have thyroid disorders, so hypothyroidism or hyperthyroidism, both of which can present with weakness. And then I'm not sure where this lady is coming from, but if she's coming from somewhere endemic to tick-borne infections, I'd be thinking about certain infectious etiologies. Then also I've read recently that AIDS can present with weakness. So I'd also have that at the back of my mind. And then on further history, I feel one particular area that I would take, I would really dig into is the medications. So statins, anticonvulsants, and then there are also obviously other inflammatory diseases that can present with weakness as well. But I'd love to hear your thoughts, Rabih.
Well, I'm not sure there's much left for me to add. I think you shared with us both how comprehensive weakness is, but how within each category you can be specific. And I think that you clearly have a strong grasp of the very wide net that weakness could capture. All those diseases can easily show up as weakness. And now the question for you, Ibrahim, is a very hard one, which is that what you just experienced and what you just described is a phenomenon that happens to many, many people who are standing in front of a patient who's saying, hey, I'm a 33-year-old woman and I'm feeling weak. And the truth is, if you think about all those things right then and there, you will not have time to move forward. So the question for you is, how can you apply a big picture principle to those diagnoses to categorize them in smaller buckets so that you can use those buckets to progress going forward? So what you just did is an amazing A through Z list of categories. And now the question for you is to make it actionable. You have to divide it into vowels and consonants, or you have to divide it into the first 10 letters and then the next 5 letters, or somehow divide it. So how would you go about dividing and approaching this DDX to make it actionable for this patient?
I think the first thing that comes into my mind before actually asking for further questions from the patient is the patient demographics. So this is a middle-aged female. So I'd put inflammatory autoimmune conditions on the top of my list. But then there are also other questions within the history that I feel would be very beneficial. Things like whether this is an acute or a chronic process. Something that would be acute, I'd be thinking more about an infectious etiology. Something that is more chronic, I'd be thinking again about inflammatory neoplastic process, thyroid disorder that has been going on for a long time. And then I'm seeing a lot of great chats with a lot of great thoughts within the chat. So something whether this is flaccid versus spastic. I think I mentioned ALS within my differential. So ALS would be something that is mixed. But then for something like multiple sclerosis, it will be something that would most likely be flaccid because it's peripheral nerve involvement.
Amazing. Okay, we did a skit last time. I'm going to play this patient. I'm 33 and I'm here with generalized weakness. What do you think you want to do next, Ibrahim? I'm right here.
Okay. So before proceeding into the physical, which I think is important as well, I'd like to ask you a couple of questions.
Sure.
So did you notice this all of a sudden, or did it come gradually?
Kind of gradually.
Okay. And so when did it start? And did
But
you notice that it had started with something in particular?
it started about a couple of weeks ago.
Okay. And then is it
David's history?
and then is it becoming worse or better?
Excellent. It's becoming it's about the same actually.
Okay. And then have you noticed any associated symptoms? Something like fever, weight loss,
Okay.
decreased appetite, constipation?
Let's pause. Do you see what you're doing there? You're really trying to understand what company is this weakness keeping. And I think the fact that when you are faced with the patient in front of you, your thoughts are very different than what your thoughts were when you were trying to build it from a theoretical model. And it goes to show you that the first question in generalized weakness is, are you talking about isolated weakness, which patients just feel weak that they cannot do things with their hands or their body, which almost always is a neurological condition, versus weakness that is accompanied by something else, weakness and not feeling well, weakness and myalgias, weakness and fevers. So weakness is one of those things, Ibrahim, that a lot of the people use the word loosely. Medically speaking, weakness means neurological weakness with reduced muscle strength. But in the English language, the word weakness is used to overlap significantly with fatigue, with lethargy. And neurological weakness is almost always isolated, that patients just say, hey, I cannot use my body, but I don't feel badly otherwise. Patients with stroke feel weak. Patients with multiple sclerosis will feel weak. But patients with hypothyroidism or tick-borne diseases will not end the conversation of weakness. They'll tell you about all the other things they're experiencing. So I think that's the key question, is to listen for or ask for any accompanying symptoms. Is this weakness alone, or is this weakness with something else? And if it's weakness with something else, we're probably not going to need Aaron and Aaron's advice because it probably will not be neurologic. But if it's weakness alone, oh my gosh, we're probably going to have to localize a lesion. And I'll just share with you one other thing that comes from the kind of experience that you just had now. This is why seeing patients in real life just forces you to become very practical about the next steps. And this is an observation that's not studied, but it comes from direct patient experience, which is the following observation. If a patient tells you that they're very weak just sitting there, like, I just feel weak, that means they feel weak without even trying to move, which tells me that it's not neurological weakness, because neurological weakness is weakness while you try to do something and then you feel weak. In neurological weakness, you should not just feel weak sitting there. So my first question is, oh, I'm so sorry to hear that. Do you feel weak right now sitting here? And the patient will either say, oh no, but as soon as I get up and I move my legs, I fall to the ground. Or, oh no, as soon as I move my arm, I feel weak. But if the patient says, oh yeah, I feel really weak just sitting here, well, by definition, she's weak without having to move anything, which means it's probably not neurologic. So what company is the weakness keeping? And is it prominent at rest or only with motor movement is a very, very helpful box, which helps us take your very impressive and thorough differential diagnosis and helps us put it in smaller pieces to be able to enact this deep knowledge that you have to the benefit of this individual patient before us. Any questions about any of that?
Well, I think that was pretty comprehensive. So thank you, Rabih.
You can give me feedback on how bad of a patient, standardized patient I am later, okay? I'm sure I can do better. All right, Debbie, tell us more, please.
So great discussion so far. I think Rabih also predicted some of the features of the case, and I'll try to answer some of the questions you posed. This clinical journey started 3 weeks ago. The patient came to the ER complaining of low-grade fever, cough, and sore throat. And in the ER, this was believed to be an upper respiratory tract infection, and they gave her symptomatic treatment, and fever resolved, but fatigue and generalized weakness persisted. So she came another 2 times in the next 2 weeks to the ER, and they believed that this was like post-viral asthenia, and the labs taken at those times were normal. The physical exams performed were also normal, and they discharged her home in both cases. But then she came for a 4th time to the ER, and this time she also reported other symptoms. She endorsed generalized weakness, but also vomiting, also unsteadiness that provoked her some falls in the last week. And their relatives reported that the patient was saying inconsistent responses to some of their questions. She didn't reported any visual or sensitive symptoms, and no fever from 2 weeks ago, and no other symptoms. I can stop there and then go to the next algorithm.
Yeah, so I don't know, Rabih, would you like me to go first, or?
Oh, I would be honored to follow you, my friend. You're taking you lead, and I will dance with you.
Okay, so I think the fact that this patient had an upper respiratory tract infection really brings the case closer. The reason for that is that I once read that sometimes when someone has something that is incidental but does not appear to be as severe, it can sometimes unmask an underlying process that had been going on for a very long period of time. So again, this is a middle-aged female. So I'd be thinking about something autoimmune or inflammatory that has been going on, particularly with the normal labs. So sometimes the labs can be normal, something like myositis. So I'd keep that probably on the top of my differential. And then something that I actually saw one time in the clinic was something known as the post-viral fatigue syndrome. I'm not sure about the specific epidemiology of this syndrome, but it can present with fatigue following an upper respiratory tract infection for almost up to a couple of months, actually. So I wonder if this patient has that. And then again, I wouldn't also rule out other autoimmune processes such as MS for the time being before the physical examination. But yeah, Rabih, would love to hear more.
Yeah, no, absolutely amazing. I think Ibrahim, you're latching onto the key pieces of data, which is that she had a URI syndrome with normal labs, and then unfortunately has evolved. And you did two things that are very wise, which is first, you didn't assume that her illness began with her URI. You're open to the possibility that the illness time course is long before that, and the URI just exposed a vulnerability that she had that was previously subclinical. And I think that that actually is really important just to maintain openness to the lack of knowledge of the time course here. And we also don't know what her labs will be today, because it seems that she now has symptoms distinct from what her symptoms were originally, which is now featuring falls with weakness, disequilibrium, and vomiting. So things have changed for her, which pushes us to reassess. But the only thing that I will add really is this is the value of having a big picture schema, which is, we said, weakness is either neurologic or asthenia. Asthenia is defined as the sense of feeling lethargic or weak. And the problem with these kinds of schemas is there's an implicit assumption that somebody can only fall into one of the two buckets. Either they can have neurological issues or they can have a systemic fatigue syndrome. But the issue is that patients can have inflammatory neurologic disease. And you already gave us an example of how patients can have post-infectious neurological syndromes, of which there are many. So I think now the key step is to recognize that we're pretty confident this person's inflamed, but I really want to know if she has a deficiency along the neuraxis. Because if we're just solving systemic inflammation with fatigue, is very different than solving systemic inflammation with cortical dysfunction or basal ganglia dysfunction or cerebellar dysfunction. And I think that's the key symptom complex now. I'm most worried about an inflammatory disorder affecting the central nervous system, because a 33-year-old should never have even subtle episodes of confusion or not answering questions correctly. That would be very, very alarming. It does happen to me when I don't get to come to VMR and suffer VMR withdrawal. So it is possible, but it would be very, very unusual and rare. So yeah, I think if I were taking care of this patient in real life, the next step I would do is a quick exam. But of course, I'm sure the other data will help us too. All right, David, tell us more, please.
So just to answer some questions that was posed in the chat, generalized weakness started like a few days after the initial presentation result with upper respiratory tract symptoms, and progressed to the day she came for the fourth time to the ER. So post-medical history was none. She wasn't with any meds, and social history was non-contributory. Family history, her family was from Morocco, but she lived in Madrid, and she was born in Spain. Yeah. Also, no health-related behaviors important. Vitals were normal in the ER, but the patient looked unwell. She came to the ER in a wheelchair because she couldn't get up without falling. The cardiovascular exam, pulmonary exam, and abdominal exam were normal, and there are also no rashes and no leg edema or other symptoms. For the new exam, he was sleepy, inattentive, disoriented in time and space. And she intoxicated with complex commands. She couldn't follow more than two sequence orders. Although naming and repetition were preserved. The upper and lower limbs were in the gravitatory maneuvers were normal, but in the overall muscle balance, it was 4 out of 5 globally. And she also had slight neck stiffness and bilateral Babinski. The sensitivity exam was normal, but we did not trust too much that exam because of the kind of confusion that the patient presented. She was unable to stand up, so rumbar and gait was not examined. And she also had bilateral dysmetria in toe nose and knee test, and this diaconokinesis. The cranial nerves were normal, and I think that's all the exam.
What do you think? Wow, what an incredible exam, huh?
Yeah, I'm not sure if I've heard this correctly, but David, did you say that the Romberg was not tested, or was she normal on Romberg?
Romberg was not tested because she couldn't stand up. She just fall to the ground if she tried to stand up.
Okay. So I think, to be honest, with this diadokinesia, as well as the neck stiffness, it brings up the CNS hemorrhage differential much more higher than other differentials, at least for the time being. So I'll keep that as the top of my differential, most likely. But also I feel that there are other differentials that can result in neck stiffness. I know that the usual teaching is subarachnoid hemorrhage versus meningitis. But then there are also things like hypothyroidism. And when you think about it, it makes sense because hypothyroidism results in generalized muscle stiffness, can sometimes result in weakness. So it can also occur as neck stiffness, metabolic disorders as well, certain types of medications, steroids, and then also inflammation of any kind of the brain. So this can happen due to Lyme disease, meningitis, etc. But as I've mentioned, with the cerebellar signs and the neck stiffness, I'll probably have something like cerebellar hemorrhage on the top of my differential. I'd love to hear your thoughts, Rabih, though.
Yeah, no, I completely agree with you. I think that, you're in a situation where you have cerebellar signs, and I'm curious, Ibrahim, when you hear cerebellar signs, you translate that into cerebellar disease. I'm curious how you're making progress on saying cerebellar disease suggests cerebellar hemorrhage. So can you walk me through how you got from, okay, this person has cerebellar disease because I see that on exam. What made you prioritize cerebellar hemorrhage?
Yeah, I feel it's probably the neck stiffness. It's most likely a knee-jerk reflex that I just had with the extension of blood into the neck. But then I wouldn't rule that out. The reason why I said cerebellar hemorrhage is because I feel that impacts the management so much greatly. So you don't want to look into other differentials and miss out cerebellar hemorrhage, and then the patient could deteriorate further. So I would approach this patient with imaging first.
Absolutely.
But yeah, I'd be up to other differentials as well.
100%, absolutely superb. I couldn't agree with you more. I think as a general reflex, whenever you have a central neurological disease, CNS disease, you should have 3 categories as your priority. The first is a vascular phenomenon, be it bleeding or ischemia. The second is a compressive syndrome, so hydrocephalus, compression or mass effect. And the third is inflammatory diseases. So here you should wonder immediately, is this cerebellar vascular stroke or hemorrhage? Is this cerebellar compression from a tumor? Or is this inflammation of the cerebellum, be it infectious or otherwise? So how can we make progress? You said it. She has neck stiffness. You are very wise to say that neck stiffness can be anything in the neck that restricts movement. However, the associated neurological dysfunction along with neck stiffness suggests that the patient has irritation of the part of the neck that involves the nervous system, hence the meninges. So then the question is, what causes meningeal irritation? It's actually inflammation or hemorrhage, as you said. So I think that the combination of these two findings makes a cerebellar compressive process much less likely. And now we can use the concomitant meningitis to say, is this bleeding or is this inflammation? And for me, the time course here is the most powerful variable. A cerebellar hemorrhage is almost a very, very, very severe and usually life-threatening disease, usually. Amanda will tell you that it's usually life-threatening and sometimes can show up with very minimal symptoms, as we had a case presented by John who had a very, very subtle findings of just nausea. So it can sneak up on you. And so for that, I commend you for prioritizing it. But if you're playing base rate, somebody with cerebellar hemorrhage, if she's had cerebellar hemorrhage for this long, she would be probably much sicker, but it's more morbid and she's vomiting. We should pay very attention to that. So for sure, a trip for imaging is very, very important in this patient. And so I think we now are dealing with a post or para-infectious central neurological process. Because we don't know if she's having a syndrome that is post-infectious or that she has an ongoing infectious disease process quite yet. And I think if we were to localize where it is, she has cerebellar involvement, and then she has parenchymal involvement. The meninges are involvement, but the parenchyma is involved because she's confused. So what should happen next? This is the moment where a mistake can very easily happen. There is so much momentum towards the brain that you can easily forget to query the systemic system. So this is the moment that you're going to evaluate the brain to the ends of the earth for this 33-year-old who is this sick. But this is the moment to not miss a subtle systemic clue. Is she lymphopenic? Does she have an elevated CK? Does she have electrolyte issues? Because if you don't look at them now, you will, and if you just focus too much on the brain, you're much more likely to be subject to the distraction phenomenon. So for me, she's getting a picture for sure, but I am so hyper-focused on her systemic evaluation because this is my last chance to not get locked in to the tunnel of neurological evaluation we're going on. Yeah, very, very interesting case. And I'm curious what David has in store for us.
Amazing discussion. So I'll give you some first tests. The labs, the CBC was normal. There were no cytopenias and no leukocytosis or anything like that. And the chemistry was also normal. The sodium potassium chloride was normal. Creatinine was normal. Glucose normal. Liver test also normal. CK normal. TSH normal. Complement wasn't low. CRP was not elevated. Urine analysis was also normal. Immunoglobulins were also normal. CT head was done in the ER, and they said that the patient couldn't. She felt unwell and couldn't stay all the tests well. So the quality of the exam was not the best, but they saw unspecific lesions in all the brain, including cerebral lesions and also in preferentially in the white matter. I'll later tell you more of the imaging, but I'll tell you that also lumbar puncture was done. The aspect was clear. Glucose was 64, or in the serum was 85 glucose. Proteins were 57 milligrams per deciliter, less than 5 red blood cells per microliter, less than 5 white blood cells per microliter, and initially some of the microbiology tests were pending, but I'll tell you that the PCR for enterovirus, H, varicella zoster, and herpes simplex virus were negative. I'll leave you there and then tell you.
Oh, sorry, I didn't mean to interrupt you. Sorry, go ahead.
I think there's probably one more aliquot with two other tests, and then we'll tell you the evolution of the case and the final DX.
This is so intriguing, David. Thank you so much for presenting it. And Ibrahim, I feel a little bad that on your first ever discussion that you're dealing with an incredibly complicated case. And I think one thing that would be really helpful for everybody, honestly, because it really is getting very complicated, is before you share your thoughts, if you wouldn't mind summarizing the problem. And in other words, trying to give out a problem representation so we're all on the same page about what we're really tracking in this patient. So what would you say?
Okay, so is this question for everyone or?
Oh, everyone should try it, but I think yours will be our gold standard. So give it a shot.
Okay, so I can see that this is a middle-aged female who's presenting post-upper respiratory tract infection with symptoms that are suggestive of cerebellar involvement. But then on CT, the patient was shown to have multiple CNS lesions. But that being said, I feel probably I'd have an infectious etiology on the top of my differential, but then the LP does not seem to suggest an infectious etiology this patient might be having. So again, I wouldn't rule out an autoimmune or inflammatory process that has been going on. However, that being said, I feel that in order to best be able to approach this patient next, it will be better to characterize the brain lesions themselves. So are these brain lesions, for example, periventricular, or are they diffuse throughout the brain itself? Are these happening within the white gray matter demarcation, or are they again diffusely throughout the brain itself? How do they look like? Are they circumscribed, or do they seem to be going through all different places without really an area that you can demarcate? So those are my initial thoughts. But yeah, but I'd love to hear more about yours.
Oh no, that was awesome. You know, it's really cool. I want to introduce you all to my mother-in-law. You all are probably seeing that I'm chatting with somebody on the side. Come say hi. She's really shy. Her name is Catherine Yu.
Hi there.
She is almost retired. She's nearing the end of over 3 decades career. And Ibrahim, I think she's sharing very much your thoughts.
Yeah.
What did you get? We got TB.
I was thinking about fungal or TB diseases, or even HIV related, maybe CNS lymphoma or something.
Oh,
great thoughts. That's exactly my differential.
Yeah. And then yeah, and I love, Ibrahim, how you incorporated the lab and the LP to like help you sway the probabilities. I think honestly, I was just looking at time. I think we have time for maybe a 5-minute breakout room, because David told us there's not much left in the case, and I think we should try to get as much information as we can from the crowd. So why don't we go into breakout rooms? Oh, and actually, I see one important question. So David, do you mind letting us know? Was it leukocytes? Are they lymphocytic or neutrophils? Do you know?
Oh, sorry, I I didn't look at, but that was not what I said. Sorry for the misunderstanding. But glucose was 64 in the liquid, and in the serum was 85, and proteins were 57, but there were less than 5 white blood
less
cells.
than 5 cells. Okay.
Yeah.
Very, very helpful. All right.
I'll tell you another data just for making things a little bit simpler. HIV was negative. Okay.
HIV negative. Okay.
Oh,
okay.
good.
Okay. All right. So we'll go into breakout rooms for about 5 minutes, and then and we'll come back. See you soon. Okay. Let me make sure we have. Yeah. There you go. I should just say, if you cannot go into a breakout room or prefer not to, please feel free to hang out here. But I think it's a really, really good opportunity to share your thoughts with a smaller group and chat with people you may not have met. All right, see you soon. Hey, all right, y'all. Welcome back from the breakout room. Ibrahim and I were having a great discussion, and as always, he's on top of it. I'll just share one observation real quick, which Ibrahim outlined, that he's making a differential diagnosis for brain masses, infections, or cancers. But very, very early on, even though we don't know that this patient doesn't have any systemic masses, the probability of her having an occult systemic process metastasizing either infection or cancer to the brain is important to recognize. But we have to acknowledge that at this juncture, there's no signal towards that. There's nothing on exam labs or imaging that suggests that she has an occult systemic process. So if we can take a leap of faith, that we should take a leap of faith, but not commit to the idea that she has CNS restricted masses so far. That differential diagnosis is very, very different than finding masses scattered throughout the body that are going to the brain. So the question really is, what kind of infectious or malignant disease process can cause brain devastation in isolation? And the truth is that the DDX isn't that broad. Immediately, viral infections causing encephalitis are unlikely to cause this degree of mass formation. There are a couple of bacterial infections with TB and nocardia leading that list, a couple of fungal infections with cryptococcus leading that list for sure. And then some very unique molds that are found in the soil. They're called dematiaceous molds, and they only go to the brain. And then Ibrahim astutely mentioned parasites, and neurocysticercosis is really, really important to think about. And within cancers, there's not that many cancers that can go just to the brain alone, though melanoma is a notorious mimicker. And of course, this person could have multifocal CNS lymphoma, but I don't think she has any of those things. The final category to entertain when a case is so unique in its devastation of just the CNS is to think of the demyelinating category. And whenever you're thinking demyelination, there's only one diagnosis within the demyelination category that includes MS, includes neuromyelitis optica. Only one diagnosis by definition that features encephalitis. All patients with MS, most patients with NMO, and most patients with MOG should not be confused. And when somebody is having this degree of brain masses in the context of encephalitis, we really have to entertain the possibility of ADEM, acute disseminated encephalomyelitis, which you will read is a classic, this is a classic case of a young woman who has a post-URI syndrome with devastation in her brain. Now, why is that hypothesis actionable now? It's because you can spare the patient the arduous journey of brain biopsy and systemic evaluation by doing one simple thing right now. And that one simple thing is to get an MRI of the spine, because infections don't go to the spinal cord. Tumors don't go to the spinal cord as often as ADEM will cause spinal cord lesions. So for me, I'm right there with you, Ibrahim. I think we should evaluate infections. I think we should evaluate cancers. But I think that trying to be a step ahead and realizing that this young woman is having disproportionate devastation in her brain with no systemic signature is a marker of the unusual nature of this case. And you said it from the get-go. You said she's a young woman. I don't want to lose sight of an inherent vulnerability she has to autoimmunity that this infection may have triggered it. You said that in aliquot 1, and I'm worried that that arc of thinking is coming true. And I would really think hard about something that's not often done in a patient with brain masses, is to do an MRI spine to pull out a demyelinating disease away from the base rate. Any questions about that, Ibrahim, before we hear more from David?
Yeah, I think that was pretty great. Excited to hear the last aliquot from David.
All right, David, tell us more, please.
Okay, so you were pretty good at that discussion. There was an MRI was done, and I can show you just a few images. I see. So, do you see that? Are you seeing that, right? Well, this is some images from the MRI. There were disseminated lesions preferentially in white matter, but also some in the cortical, subcortical regions, and you can see also this one in the medulla, and the patient couldn't tolerate well all the MRI, but there were also seen some lesions in the cervical spine. Other tests were done, including anti-MOG. You can return to the whiteboard. Other tests were done, including anti-MOG and anti-neuromyelitis optica antibodies in CSF and in serum that were negative. But in the lumbar puncture, there were positive oligoclonal bands. Autoimmunity, the rest of the autoimmunity was normal. And I'll leave you with that and then tell you the final year.
I gotta say, David, this is an incredible case presentation. Really, like, so well structured and really, really fascinating. What do you think, Ibrahim?
I think with the oligoclonal bands, I'm thinking about something like MS. But then also on the MRI, you see that there were some lesions that were visibly, like there were some lesions that were a little bit faint, and then there are others that appeared a little bit active. So I think MS is probably on the top of my differential. But then I'm not sure if David has such a straightforward diagnosis with us here today with oligoclonal bands and MS. So yeah, so that's what comes into my mind right now.
Yeah, I think I agree with you that you've captured the category of disease this patient probably has, which is that she probably has demyelinating disease of the central nervous system. And I think that inference is a wise one whenever you have white matter lesions. And then I would say the most powerful test result this patient has is she doesn't have brain lesions alone. She has brain lesions with spine lesions. That combination is very evocative of demyelinating diseases. And I think, of course, you can have a systemic autoimmune disease cause CNS demyelination. The most notorious cause of that is sarcoidosis in the United States, but neurobichette's, as I read recently, can also do it. But we have no systemic signature in this patient. So I think we say, okay, what are the demyelinating diseases that affect the brain? And there are 4 of them that are well described, and some of them are a little bit less well described. And the 4 are multiple sclerosis, as you said, neuromyelitis optica, and MOG, myelin-associated glycoprotein, and then ADEM, acute disseminated encephalomyelitis. So we know here that the MOG and NMO analysis is negative, which reduces those diseases, but those diseases don't present with as much as the Marburg tumor factor of MS or ADEM, acute disseminated encephalomyelitis. At the end of the day, I think that this patient certainly needs immunosuppression, but my leading diagnosis would be ADEM, acute disseminated encephalomyelitis, and let me explain why. ADEM is an imaging-based diagnosis. In most patients, though, biopsy can be confirmatory, and the imaging pattern here is very, very consistent with it. So you see three things with ADEM. You see asymmetric, mass-forming white matter disease. So asymmetric, you saw how asymmetric it was? Mass-forming white matter disease. You see symmetric gray matter disease, and then you see spinal cord disease. And what are other characteristic features that neuroradiologists look at? They can actually look at very subtle things like the pattern of enhancement of the contrast. So in ADEM, you have an incomplete ring of enhancement. In cancers and infections, the enhancement ring is complete, it's full. But in ADEM, there's a little bit of a break. And if you look at the DWI imaging, the DWI restriction is in the peripheral rim as opposed to centrally with infections. Long story short, the imaging characteristics are what define acute disseminated encephalomyelitis in the vast majority of patients, though biopsy is the gold standard. I'm not sure if biopsy was pursued here, but I think that a post-infectious, devastating, mass-forming neurological syndrome with asymmetric white matter changes, spinal cord changes, and gray matter changes is very, very suggestive of acute disseminated encephalomyelitis. And I think this patient will really, really, really benefit from aggressive steroids very quickly, not to be delayed by trying to look for anything else for now. So that's where I'm at, but I think we have a lot to learn from this case and a lot to learn from David. So I will pass the mic to you, my friend.
So, well, you were completely right, but I'll summarize a bit of the evolution of the case because it was a little bit difficult. A patient received methylprednisolone, 1 gram per day, 5 doses, and she improved incredibly. Unsteadiness resolved, the Babinski resolved, the confusion resolved. It was great. The patient improved perfectly. There was some dysmetra left and some unsteadiness, but improved a lot. But as she didn't resolve completely, she also received plasmapheresis sensitivity, and she was well, but after that and during that, she started complaining also of some sensitive symptoms. Dysesthesias in the first in the arm, then in the genital region, and we were not completely sure. The first report of the MRI by the radiologist were that this was compatible with ADM, and we thought that was the case. But in the next weeks, the patient keep reporting new sensitive symptoms. And an MRI was repeated 1 month after the first one, and there were new lesions, even that she received steroids and plasmapheresis. So we wasn't sure about if this was ADEM or multiple sclerosis, presenting in a very rare way. But the patient also, after resolving this confusion and also these symptoms, the patient reported that 6 months ago she had an episode of urinary incontinence, and we didn't know if this was flare that was very destructive of MS, or if this was but the oligoclonal bands also made us question a little bit the diagnosis of the ADEM, because it's not the typical finding in this disease. And there's also a bit of overlap between these two diagnoses, and there are, I don't know exactly, but maybe 20% of something like that of patients with ADEM that progress to MS. So the patient started with natalizumab later because we were not sure of this not being MS. And well, that's the case. The patient improved greatly, but there were some findings that were not totally compatible with ADEM. Also, well, the discussion was started.
Wow, David, what a humbling case. And I'm so glad that she was in your care and your hospital's care, because you know, being where she was and ending where she is now is just wonderful. And you know, I can't tell you the number of instances where patients with brain masses don't have a great outcome. I think that's the vast majority. And the fact that you all suspected this diagnosis so early on, and not only guided this patient to a marked improvement, but also seemed to have done so without exposing her to the need for a brain biopsy and wasting time doing a systemic evaluation, being so focused on what's going on, is very admirable and commendable. I really, really respect you all for doing that. But today is all about our dear friend Ibrahim, who's doing his first discussion and latched on to the final diagnosis very aptly and correctly. How does it feel?
Feels great for me. Feels a little bit sad for the patient. I wished if they had ADEM, if they knew like 100% that they had ADEM instead of MS, because then like she wouldn't have to have this debilitating disease for the rest of her life. Whereas in ADEM, it's just one episode and could resolve completely. I hope this patient is doing well now. But yeah, it's been fun discussing with you, Rabih. So thank you. Thank you everyone for helping in the chat.
I thought you did a fantastic job. And I think that, you know, the textbook will tell you that ADEM is a monophasic disease, but as David pointed out, a large fraction of patients go on to develop secondary demyelinating diseases. And it's not too surprising when you have so much devastation in your brain to go on to develop something else. And, you know, the relationship of demyelinating diseases to each other is very interesting. So how patients with ADEM can develop MS, but also it's really interesting that these diseases can actually be triggered by either unknown infections or known infections. I was recently part of a case of a patient who had NMDA encephalitis and NMO encephalitis. So our attempts for precision on one specific category does fight the pathophysiology, which is a little bit more diffuse and less elegant than the textbook would have you say. So the two patients that I've had who were diagnosed with a severe encephalitic demyelinating disease both progressed to a chronic demyelinating disease, which is not too surprising given just how devastating this event is. But I really, really admire you for your discussion. I think it was very hard to figure out, is this patient going to have an inflammatory disease of the system, or is this person going to have a neurological disease? And it turned out that you had a very hard case of both, an inflammatory disease of the central nervous system. And I hope you had as much fun as I did. And thank you, David, for an incredible case. So well presented, really, really educational. It lives up to the hype that we've now come to associate your name with when presenting. I'm curious, I mean, what before we learn from Marino, I'm curious what your takeaways for what was it like to be involved in this patient's care, and what were your biggest takeaways from it?
Well, the first, this case was difficult because in the first day when we admitted the patient in the floor, she was pretty unwell, and she had a lot of risk. So luckily the things were done very promptly. And the first day of admission, she had the MRI and the LP and steroids initiated, and she responds very, very well. But well, a first learning is that in patients complaining with generalized weakness, even after upper respiratory tract infection, we have to do a thorough exam to not miss these kind of things. And a second learning is that in the myelinating diseases of the central nervous system can present in very different ways, but the encephalopathy is almost only associated with ADM, although, well, there are a bit of other rare cases such as this one that could be other things. Well, we didn't suspect initially any infectious or other cause because the LP helped a lot, not being phagocytosis and all of that, but that could have posed another additional difficulty that in this case at least was not appeared. So.
So well said. Yeah, so well said. It's so true. The more we know, the more nuanced and complicated things can get, but hopefully the better that our care gets for the patient. Thank you for that great summary. All right, Marino, take us home, please.
Oh, wow. What an amazing case, David, and really great discussion from you, Rabih and Ibrahim. Really well done. So let's start with teaching points. I have a lot for you today. So first of all, we got a clinical picture of weakness, generalized weakness, and weakness as a soul shift complaint is actually a very vague one. So we must ask a lot of questions in order to dig out and look what this patient has. So is it true weakness or is it a subjective weakness such as fatigue or lethargy? So when we get to the physical exam, we will see that we can get a lot of clues to try and differentiate and narrow down our differential diagnosis. So some quick differential diagnosis of weakness are neurological disease, muscle pathology, asthenia, metabolic disease, medications, and inflammatory disease. So when we get weakness, we must ask the patients questions such as the onset, when did it start, if the condition has progressed, if there is any associated symptoms in order to localize it, and if the weakness is isolated or generalized. So clues for neurological weakness, like that we can see really fast, is that if weakness is present with movement, we should probably narrow down our differential to a neurological cause. And if weakness is present at rest, it suggests more of a non-neurological disorder, such as an inflammatory disease. So this patient was really young and didn't have any history of that should have made us concerned about any metabolic disease or any autoimmune disease. But patients, normally the bracket of patients that get autoimmune disease are young females in childbearing age. So this patient exactly fits that category. So we should try to think about bad genetics, bad luck, and bad environment in the case of this patient. Later in the physical exam, we got massive clues about what this patient can be presenting. So during the physical exam, she had bilateral cerebellar signs and neck stiffness. So quickly, the team decided to get a CT to rule out hemorrhage, but it was inconclusive due to the patient restricting to the study. So quickly, we talked about the categories of central nervous system disease. So we have 3 buckets mainly: vascular disease, either ischemia or bleeding, compression from hydrocephalus, or inflammatory disease. So in this patient, we quickly rule out compression and we shifted our focus to vascular and inflammatory, because both of those can present with neck stiffness. To differentiate between these two, the time course is key, because vascular tends to be more of an acute onset and inflammatory is more of a subacute and insidious onset rather than hyperacute, such as vascular. Although many vascular etiologies can present as a subacute, like subacute as the inflammatory bucket. So later, this patient got an MRI, and the patient presented with multiple lesions in the white matter, which could also have suggested us more of an occult systemic process like malignancy. But as we talked earlier, this patient didn't have many risk factors for malignancy and didn't have any family history, so it was lower yielding diagnosis. In the setting of this patient, ADEM, acute disseminated encephalomyelitis, had to be evaluated, and the MRI surely gave us clues for that. So the patient presented with oligoclonal bands on lumbar puncture, which suggests demyelinating disorder, and she had involvement in the brain and the spine, which even confirms our hypothesis of ADEM even more. So the classical findings of ADEM on MRI are asymmetric white matter changes and symmetric gray matter changes, mass forming, and spinal cord involvement with incomplete ring enhancement. In the diffuse weighted imaging part of the MRI, there could be restriction in the peripheral rim. And for management, as this is a quickly devastating condition, if you rule out infection, you should end up in starting immunosuppressive therapy with steroids, because patients can quickly benefit from that, such as this patient did, that in 30 minutes, she quickly improved, even though later she got more complications of the disease, but short-term improvement is massive for her. So that's what I have for you, and thank you.
Oh my gosh, the amount of focus and attention you've had to do to be able to grab all that, that's amazing. That is so cool. Very, very well done. All right, y'all. Thank you. I don't know if we'll be able to replicate this VMR for a while. So David, thank you for an amazing case, Ibrahim, for a fantastic discussion. And Yaz, I don't know if you're have a second to please, as you mentioned on WhatsApp, to plug your fantastic event tomorrow before we go.
Oh, thank you so much. Hello, everyone. Amazing case. Great, David. I really liked it. And congratulations, Ibrahim. You really did a great job discussing today. And before we finish, tomorrow, all IMGs, we have a very big surprise. City Solvers, the IMG initiative, will have our first session with Dr. Pritish Tosh. Please join us and grab all your answers you can have. He's going to give us insights about the application process as a former APD of Mayo Clinic. So I hope to see you tomorrow there. Thank you.
It's amazing that you all have former APD of Mayo Clinic coming to join us. That's really, really cool. Yeah, tomorrow at 9 a.m. Pacific, 12 p.m. Eastern. Hope to see you all there. Bye.